All right. Thank you all for being here. My name is Arif Noorbaksh. Please just call me Arif. No doctor unless you're my patient. I'm the founder and one of the psychiatrists at Continuity Mental Health. We're a small group practice doing med management and therapy kind of in a very collaborative way. We do a lot of case conferencing and other things. Um, we're only about 5 months old, I believe, tomorrow. So we're relatively new to the scene, but very happy to be part of the community trying to improve access to mental health. If you have any questions, concerns, would like to refer a patient for med management or other services, our contact info is at the bottom of this title slide. And then we have a lot of information and patients can self-schedule with us directly through the website, which is listed below too. All right. Um, so just a little bit about myself. I'm a kind of a UT person through and through. So I went to UT Austin for undergrad, UT Houston for medical school, and did my residency at UT Southwestern in Dallas. Been in Texas for quite a while, but lived in part of the Northeast for a little bit and a couple of other places before my career in medicine. I've put my email address on here if you'd like to contact me directly with any questions, concerns, want to collaborate on patients. I really enjoy those things. So please do reach out if I can be helpful. No real disclosures to mention aside from I am a patient who has treatment resistant depression. Took me about 10 years to find a combination of things that worked really well for me, including a lot of the things that we'll talk about today. And so the perspective I bring on this is both as a clinician that treats patients with TRD as well as a patient. So kind of both perspectives there. So a little bit about what we're going to be talking about today. So we'll talk about how do we define treatment resistant depression, what I think about when I'm seeing a patient for the first time with TRD or a history of TRD, how we approach medications. Very briefly, any one of these could be like a whole lecture series, really. And then we'll spend some time talking about interventional treatments, which I'm very excited about, and I think we know patients who would benefit from interventional treatments are not getting them. So it's something we'll kind of talk through a little bit as well. And then a few adjunctive treatments like supplements and other things that I try to incorporate into my practice that are evidence-based and found to be helpful. So let's start a little bit about TRD. So what is TRD? Um, so the take-home message here is that there is no formalized consensus definition of treatment-resistant depression. There's kind of what is used in the research when they're doing research on the TRD patient population, and then there's kind of the real-world clinical implications of kind of how much treatment patients have received and how we decide to define that. And so in the research, the kind of most common definition is two medication trials from two separate medication classes. Every now and then, they'll use a trial of psychotherapy, and usually they specify CBT or some other kind of structured therapeutic modality as being one of those trials, but usually it's two meds. And then in the research, typically those things need to be have been tried within the same episode, the current episode of depression. So if they happened during previous episodes, they don't quite count. In the real world, however, I think we all know there's much more complexity and nuance to kind of the journey patients have had, and so they typically many medications, different medication classes. Have they done augmentation trials where we add a second medication to the first? Have they undergone psychotherapy? Do we count trials from multiple episodes of depression? Did they have adequate trials? So did they have to stop early because of side effects, or were they not as adherent, like they missed half their doses, and so maybe that doesn't quite count as a medication trial? And then what do we do when a patient's partially responded? So their PHQ is gone from like a 25 to a 17 great response or some response, but we're not at remission, which is always the goal. And so in the clinical world, I think the definition can vary quite a bit. And where this really matters or where this really impacts care in my practice anyway, is prior authorizations. So how does the insurance company define treatment-resistant depression? How much access do I get that patient to various new medications or interventional treatments that we're trying to use? Um, uh, TRD is very common, however, and this may make me a bad psychiatrist, but I'm going to say it anyway. Medications are just not that effective. So your first trial, you have a less than 50% chance of getting a response to that first medication. And then for every subsequent medication trial, that response rate really drops. So it drops to about 25% for number 2, and then even less than that, 10 to 15% for number 3. And so about a third of patients end up with a TRD kind of, or qualifies as a treatment-resistant depression patient. And then there's a couple of things to think about in terms of you need at least 6 to 8 weeks on a med to know. It's got to be a therapeutic dose of the medication. And there's a lot of side effects that impact this. And that's a big, I think, reason that a lot of patients end up treatment resistant because they experience pretty significant side effects. What I think about when I see my first patient, and we're going to try to get through these slides in about maybe 30 minutes or so, a little bit less, and I want some time for discussion and questions for sure. What I think about a lot is, do we have the right diagnosis? So really revisiting the history. Is this a bipolar depression that hasn't been diagnosed correctly? Is there something else here going on that we're not seeing? Is our history accurate? Is there a trauma history that we haven't picked up on that needs to be addressed that's impacting care? Are the medication trials that we've listed accurate? Are there medical or other comorbidities playing a role? A big one is usually substance use. So maybe when you first saw the patient, first started treatment, they were maybe smoking cannabis like with the boys, on a weekend, once a month maybe. And now and they haven't disclosed this to you or it hasn't come up. They're now smoking much more frequently or using alcohol much more frequently. Do they have uncontrolled diabetes? I've had at least one patient in my career whose initial presenting symptom of his pancreatic cancer was, to me, with pretty severe sudden onset depression that was not responding to other medications. So looking at all of these things is important, especially adherence. Adherence rates are around, the average is 60%. Which is not fantastic, and that can really affect response rates. And then I always think about, there's probably 100 or more different ways of case formulation, ways of conceptualizing case formulation. This is one that I was taught in training that I still use, that I find to be granular enough to be able to make decisions based off, but not too simple, kind of like the old axes designations. And so it's the biopsychosocial model, but splitting it up kind of temporally, kind of when things happened and how they're affecting our current case. And so that's a kind of important things to note when we're looking at a TRD patient from my perspective, especially when I'm thinking about med management. How do we approach med management? Again, this is quite a long discussion. We have first-line antidepressants, SSRIs, SNRIs, Zoloft, Lexapro, Prozac, Wellbutrin, Paxil, kind of the more common ones. There's some alternative agents that we sometimes try that we don't use very often anymore because of side effects. Tricyclic antidepressants, MAOIs. These are older, a lot more side effects, maybe a little bit more effective. There's some newer medications. Auvelity is a new one that's a combination of dextromethorphan and another older agent that works differently than most conventional antidepressants. And then one that's not really for MDD, but I want to talk about because it's new and I think everybody should be aware of it, is we have the first oral medication for postpartum depression, which is Zurzuvae. It's only 2 weeks. It's quite effective. It's a neurosteroid. It works very differently than other medications, and something that I want on everybody's radar because that patient population is very much underserved. And then we have augmentation agents. The most common one you might have heard is Abilify as an atypical antipsychotic. Lithium is used sometimes. We used to use a lot of thyroid hormone, but that's fallen out of favor because it has a lot of side effects. But take home, there's not a lot of data to help us decide what medication is going to be effective and what the next step might be in the algorithm. And when you look at the data, kind of different people's prescribing habits are kind of all over the place. But the important thing is to kind of look at the patient. What's their history of medications? What side effects have they had? What side effects do they not tolerate, or what side effects might be more tolerable? Any other medications they're on, medical comorbidities. Patients with diabetes potentially might do better on something like Wellbutrin, things like that that we think about. But at this point, we've talked about how subsequent medication trials have less and less likelihood to succeed. And so the important thing, really, from a med management standpoint, I think for me, is to make sure the patient is in comprehensive care. And that starts with psychotherapy. I purposely don't work anywhere that I don't have ready access to getting patients into psychotherapy, because it is very important. You've been depressed for 2, 3 years. The kind of snowballing behavioral and thought pattern changes that kind of need to be worked on are huge, and psychotherapy is a huge part of that, as well as like behavioral activation, building in exercise, those kind of things. Interventional treatment. So I'm going to go through these in order of oldest to newest. These are all medications that we are commonly used now for treatment-resistant depression, and then we'll talk about some cool investigational ones. But this is the area that I'm most passionate about, because patients don't get to these treatments very often, and they have a far higher likelihood of success compared to other medication trials and other things like that. The first and oldest is ECT. I think when we say ECT, the mental image that comes into a lot of patients' minds is a Clockwork Orange and other things like that. I can assure you, with modern anesthesia, patients are asleep. They are being ventilated artificially. They are paralyzed so that the seizure that's triggered doesn't cause any damage. It's quite a eventful procedure. I've done quite a bit of it, but the take home here is that seizures have been known since the 1800s to improve of the symptoms of a variety of psychiatric conditions: psychosis, mania, treatment-resistant depression being kind of the top ones, and the ones that we still treat now. We used to use things like insulin to trigger these seizures, so we'd induce severe hypoglycemia. People would seize, and then they'd get a big bolus of glucose to bring up their blood sugar again. But we started using electric currents to do this in the 40s, basically, is when it became common. Fell out of favor for a while. It's becoming more common again. This is still the gold standard in treatment-resistant depression treatment. So an 89 to 90% response rate, a 70% remission rate. But despite this being the gold standard and being around for a very long time, we still don't know exactly how it works, like a lot of things, like things in psychiatry. And a lot of theories, but the big ones are that it induces plasticity. And you'll find that with a lot of the changes, or a lot of the treatments that we're talking about here with interventional treatments. We know that neuronal plasticity is deficient in people with chronic depression, especially in certain areas of the brain, like the hippocampus, and these treatments tend to reverse that. There's a lot of other potential changes that might be mechanistically linked in ECT, but plasticity is kind of the big one. And there's some EEG changes, so changes in the way the brain is working globally, that might be part of that. Adverse events. So seizures can have adverse events. I've seen a handful of complications, but generally this is a very safe procedure. Most of the complications, a lot of the complications stem from the anesthesia. So inducing anesthesia, getting them out of anesthesia, and events around anesthesia that may be complex, but by and large, well tolerated. There's a lot of fear around cognitive changes. So anytime anyone has a seizure, their short-term memory before and after that event is going to be impaired. That's pretty standard, a seizure from any cause. And so it's very common for patients who are getting initial ECT, which is 3 times a week, to not have good recollection of that time because their short-term memory is being impaired. Very rarely there are long-term memory or other cognitive changes that are prolonged. but that's a relatively uncommon occurrence. For most patients, ECT is very effective and very well tolerated and probably very underutilized. Another important thing about ECT is that there's no absolute contraindications. So for patients who ECT is safe for pregnant patients, very likely safer than a lot of medication options. It is safe in a variety of other kind of complicated medical conditions. And so it's something that, again, no absolute contraindications, relatively safe. Um, an evolution of ECT is TMS, transcranial magnetic stimulation. So there are these kind of complexities of ECT. It's an anesthesia procedure. It's kind of like an outpatient, almost like an outpatient surgery. Just let somebody in here. There we go. And that kind of setting. And so there was a lot of research put into how can we accomplish similar effects with something that's much more accessible. And so TMS, or transcranial magnetic stimulation, uses a very small but powerful and focused magnetic field to stimulate a very specific area of the brain. And for depression, that is an area on the left side, kind of right here, called the dorsolateral prefrontal cortex. And this was approved, by the FDA in 2008. So it's been around for quite a while now, and it's an area of a lot of active research. So there's a lot of different brain targets for different disorders that are being researched and used clinically. A lot of different protocols for administering TMS. You might have heard more recently of the SAINT protocol, which is kind of an accelerated TMS that they use fMRI to guide. And it's all done kind of compressed in a week and it has very good numbers, but not widely available. It's also kind of cool to note that TMS also has FDA indications for OCD, as well as smoking cessation, and it's being actively researched for a variety of substance use and other psychiatric disorders. So pretty cool modality, and very well tolerated. So it's the kind of treatment where you can kind of go on your lunch break. It takes about 20 minutes. It is, 5 days a week for 5 weeks, so it's quite a commitment for patients, but they can drive back to work. There's no downtime. Efficiency numbers, however, kind of all over the place. So remission rates are around 20 to 30%, a lot lower. But the data on this is a lot more complicated to interpret. And again, mechanistically, we're inducing neuroplasticity. We're altering kind of connectivity of different brain regions that might be abnormal in depression. So you can actually see with TMS, you stimulate this area, and there's a lot of other areas in the brain where connectivity and activity actually changes as a result. So it is affecting multiple different parts of the brain, which is kind of cool to see. Um, Adverse events. So very low rate of seizure is possible. It's very uncommon. I've never had this happen before, but it is something that's known to occur. It's more common in patients who have a history of seizure. So that's something to think about. It's more common in patients who are sleep deprived, who have drank heavily the day before and are in a mild withdrawal day of. If there are any medications that make seizures more likely, that can be kind of a risk factor. And so we screen for all those things pretty heavily before we undergo TMS and counsel patients on make sure you're rested, make sure you're not drinking, those kind of things. Aside from that, however, this is probably the safest treatment in psychiatry. I believe the biggest side effects, maybe a little bit of headache, maybe a little bit of scalp discomfort because the muscles around the magnet kind of twitch just a little bit during treatment. But by and large, very well tolerated, very few side effects, very few kind of adverse events overall. And then the next few treatments I find the most interesting and have been the treatments that have personally helped me the most and I have experience with personally. And these are ketamine and Spravato. And so I think this is a really interesting thing that we might all discuss together because there's a lot of interest in utilizing these kind of so-called psychedelic class of treatments in conjunction with therapy to facilitate much better outcomes. And so just quick pet peeve. So psychedelics, it has a pretty specific meaning in like the scientific literature. And these are serotonergic medications, things like psilocybin or shrooms, things like LSD or acid, serotonin, DMT is another one. So serotonergic medications that induce what's colloquially called a trip, or this kind of intoxicating experience that's transient, that's temporary. Um, that experience, however, with conventional psychedelics is very different from the experience with ketamine or Spravato, which is just kind of a small derivative of ketamine. These things induce disassociation, and that feeling is different. It can be uncomfortable for patients. It can be somewhat difficult to tolerate. You kind of feel disconnected from your body and your surroundings. It can be anxiety or panic inducing if the right prep work hasn't been done. So, a lot of the work around integrating therapy and these particular treatments revolves around preparation work, making sure patients know how to kind of handle themselves, grounding exercises, other tools they can use to help manage the experience beforehand. And there's a lot of thought about kind of what to do during the experience with therapy. But disassociation is something that I think is kind of the biggest barrier for these treatments because it can be uncomfortable if patients are unprepared. How this works, again, like most things, not quite sure. But we do know that these medications block this receptor called NMDA. And when you block NMDA transiently, so temporarily for about 45 minutes, there's this transient surge of a neurotransmitter called glutamate. And that is what causes the disassociation. So there's a lot of debate as to whether these drugs work without the intoxication. And right now, the consensus is probably not. That surge of glutamate is really important and kind of a biomarker of we're getting what we need to get done in the brain to accomplish the outcome. And then in the long term, we know that that surge over the days up to a week after treatment induces a really high level of neuroplasticity in the brain that can be measured pretty effectively. One of the coolest changes that you can measure from a cognitive standpoint is actually cognitive flexibility. So cognitive flexibility goes way up. Patients are able to kind of think about things, conceptualize things much more flexibly than they could before. And I personally think, although this is the hard thing to study, I personally think this is one of the most important parts about these treatments is to help patients kind of break the cycle of negative thinking, negative cognitive bias, the other things that are impacting and potentiating their depression, and able to really kind of engage in therapy in a way they might not have been able to beforehand. But how we do that with therapy is something that's actively being researched, not yet fully understood. Um, you will read in some places where they say this so there's people that advocate that these treatments are not effective unless done with therapy, and that's simply not true. We have good evidence that they work, and the research with them, when especially Spravato with FDA approval, was all around using it without therapy. It was just simply a drug study, but it is pretty clear that ketamine assisted therapy or ketamine informed therapy, these are helpful modalities, and they're certainly not harmful. And so they can be very helpful, whether you do that therapy like during the acute intoxication or whether you do it kind of afterwards in conjunction with, which is more kind of the ketamine informed therapy model is kind of up to debate. What I will say is like from personal experience, I would find it very hard to engage in therapy while under the acute effects of ketamine. I might find it very uncomfortable. But there are a lot of like kind of subconscious insights that are brought into the consciousness when you're in that state that you can then bring into therapy later and explore, which are really interesting to do. So that is where I think therapy can really fit in here. But let's go through these kind of one by one. Ketamine itself approved in the 70s as an anesthetic. Important to note, it's not FDA approved for anything psych. So it is very rarely covered by insurance. This is typically something that's only available in a cash model. It's been the first kind of randomized controlled placebo-controlled trial to prove that it was effective in treatment-resistant depression was in the year 2000, and since then there's been just a ton of research into utilizing it for both depression as well as a variety of other things: PTSD, OCD, bipolar depression. Those have good evidence. A lot of ways to administer it. Best study, or it's been studied the most, and is probably the most reliable, is intravenous administration. It's also easier to control if the patient's having a really difficult time. You can turn it off, and that acute disassociation wears off very quickly. But you can also see it administered intramuscularly as an injection, subcutaneously, and then there's a lot of mail order, kind of like Mind Bloom type places that do sublingual ketamine. That's probably the least reliable way of administering ketamine. And I don't recommend patients get ketamine treatment at home. It's dangerous. It can cause severe hypertension. It can cause a lot of discomfort, and doing it in the clinic is kind of the safest and probably the best way to administer ketamine. Efficacy numbers: 50 to 70% remission rates. These are fantastic numbers, much better than any medication I got in my arsenal. But it does have adverse effects. The dissociation, like we talked about, is uncomfortable, makes more than half of patients a little bit nauseous, which we can treat with a little bit of Zofran beforehand. It can be sedating. It can cause sometimes quite significant hypertension, which, if not caught, like if they're at home, if we don't catch that, we can't intervene, and that can increase risk of an acute heart attack or stroke. And then I've had this happen, but rarely, treatment emergent mania or psychosis. So they start ketamine, they actually have a diagnosed bipolar disorder, which is where kind of revisiting your diagnosis comes in. And then 2 weeks into treatment, they're manic. And we kind of need to change course with how we're approaching treatment. So those are things to think about. Spravato is a derivative of ketamine. So when we say ketamine, it's actually a mixture, a 50-50 mixture of two things: S-ketamine and R-ketamine. Spravato is just purified S-ketamine, kind of like the difference between Prilosec and Nexium. It's just a very equivalent difference. Spravato was approved in 2019 for TRD and what they call MDSI, so major depressive disorder with suicidal ideation. It must be taken with an oral antidepressant. It's administered under what's called a REMS program, a risk evaluation and monitoring program. And so the FDA imposes this. Every patient has to be enrolled, every provider, every pharmacy, everybody's got to be enrolled, and every treatment has about 2 pages of paperwork you got to submit. It is under kind of administered under a lot of supervision, and it's administered intranasally. So it's done in the office by the patient under supervision as an intranasal spray, and it's about a 2.5-hour office visit. In the phase 3 studies, it is FDA approved, so it is covered by insurance. In the phase 3 studies, 70% response rate at 28 days, 50% remission rate at 28 days. And these are fantastic numbers. Adverse events are the same as with ketamine. We think about these as functionally equivalent. They may not be exactly equivalent. That's something that research is trying to bear out. But there's been very few head-to-head studies. But those that have been done show them to be equally as effective. So if I can get patients to Spravato, that's always my preference because it's covered by insurance. They can continue it if they need to for long-term maintenance, which some patients do need to do. That's just it produces much better outcomes for them than a lot of the other medications they've tried in the past. And it's relatively safe to do so. So there's now patients who've been on Spravato for weekly or every other week maintenance for over 3 years now in a long-term safety study. I think they're actually up to 5. And there's no increased safety signal or issue. So this is a safe long-term maintenance treatment as well. And then last but not least, kind of like the cool new investigational stuff that's on the horizon. The most kind of well-studied one, and the one that's farthest along, is psilocybin, or the active ingredient in psychedelic mushrooms. Psilocybin is the prodrug of something called psilocin. So you eat it, it's taken orally as a pill or extract or something else. The liver converts it to psilocin pretty quickly. And then this is a conventional psychedelic. So it directly affects serotonin receptors. It causes an acute intoxication or a trip. That can last up to like 5, 6 hours. It's not short. It is in the preliminary studies so effective that the FDA gave it breakthrough designation. And so it's kind of been fast tracked. And the model is delivering it in a clinic with a structured therapeutic intervention. So 2 kind of therapy prep sessions, 2 therapy sessions under the influence of psilocybin, and then 2 kind of integration sessions afterwards. It's currently in phase 3 trials, which is the kind of trials you need to try to get FDA approval, like big, very large trials. And those, unfortunately, are not going so well. So the company that's developing and running the phase 3 trials, Compass Pathways, recently kind of laid off 30% of their staff, delayed kind of the outcome of their phase 3, didn't start their second phase 3, and so we'll see where this goes. But there's a lot of excitement around this. And then in earlier phases of the study, there are other treatments like DMT, for example, or actually psilocin, IV psilocin, that are being investigated as well, but they're not close to kind of coming to market. And I expect that if these things do come to market, we're still several years out, like 3 to 5 years out. So it's going to be a minute. And then last but not least, this is probably my favorite slide. So, adjunctive treatments that I use really commonly when I'm treating patients with TRD, or things that I think about. It's important to note that these, even though they're just like supplements or things like that, they're not benign. So, light therapy is a big one. I used to practice in the Northeast. Seasonal affective disorder was much more common up there, just because light's different, different latitudes. But light therapy and seasonal changes in mood are very common. Light therapy can be very effective. There are a lot of not clinically appropriate devices for delivering light therapy. They're not bright enough. They don't have the right tones. They're not UV protected, so they can cause retinal damage. So it's important to get a very high quality light therapy lamp if you are going to do light therapy. And then it's 10,000 lux, which is the unit of measurement at the face. With, for some lamps that aren't good enough, or like 6 inches from the lamp, which nobody can do. So you really need a good quality one, so it can be at least 18 inches away. And then for 30 minutes every morning. But this, if somebody has bipolar disorder, for example, this can induce mania in some people. This can produce more affective instability in some people. And so it's not a completely benign methodology. There's some evidence-based supplements that I recommend quite a bit. Methylfolate is a pretty common one. Some people have deficiencies in folate methylation, which affects their ability to produce neurotransmitters like serotonin, like dopamine. It's about 10% of the population, so it's not a huge number. The genetic testing can be quite expensive and is not often covered by insurance. Methylfolate, 15 milligrams a day, probably costs maybe $10 a month. You can buy it on Amazon, and so it's something that I try. Excuse me, give me just a second. And then omega-3s. EPA was a certain kind of omega-3, 2 to 4 grams a day, can be very helpful, but it's a pretty potent blood thinner, so you got to be careful. SAMe, 800 milligrams twice a day. It's quite serotonergic, so it can cause serotonin syndrome. And then the one that's probably most complicated to use is St. John's wort. It has efficacy. It's got evidence, but it has like a ton of drug-drug interactions, some of which are potentially life-threatening. So not something to use without consultation with a provider. And then the one that probably has the best evidence, but I think we all know is the hardest to get implemented. You're depressed, you're not motivated, you don't have energy. Getting people to exercise 150 minutes at a moderate to intense cadence of aerobic exercise per week, that's really hard. And I think that's one of the big places where the collaboration between med management therapy comes in to help try to kind of build those behavioral changes that can get people to remission. All right. So That is my adjunctive treatments. Thank you for listening. Questions, thoughts. What do we think?
Oh, I wanted to ask if you have anything to say
Hey,
about
Nancy.
MDMA. I thought it was going to be approved
Yeah.
last August, but then that sort of went away.
Yeah. So MDMA was being studied
Or
for
MD. Yeah. Is that right? MDMA, MDA?
MDMA. Yep, yeah, you're right. It was being studied, and still is, for as a treatment for PTSD. Same kind of model as psilocybin, with therapy, and then MDMA assisted therapy, so therapy during the acute intoxication. And there was a lot of really excitement around it. And then the institution, it's a kind of a nonprofit called Lycos that, well, it's a branch of a nonprofit called Lycos that was trying to develop it. Their phase 3 trials. Were okay, but not accepted by the FDA because there was a lot of methodological issues and a lot of potential other issues with how those studies were run. And so the FDA didn't approve it. But Lycos said that they're going to go back and rerun some trials to get more data that the FDA wants, to see if we can get it approved. I don't know of anybody who's studying it in the context of depression, but they probably will. So that's kind of on the future too, on the
If
horizon.
they look at the points the FDA objected to, and they'll revamp to accommodate those more precisely into it.
Yeah, yeah. Another one of the issues with those studies, and the issue with pretty much all studies in psychiatry, is placebo response. So when you're doing a study on a new treatment, you got to kind of have a randomized controlled trial where you have a placebo arm that's effective. And
Mhm.
if everybody who gets MDMA knows they're getting MDMA and not the placebo,
Yeah.
placebo response rates in psychiatry are like 50%. So I give somebody a sugar pill and I tell them it's going to make their depression better. In studies, there's almost a 50% chance it will. And so the idea that people know they're getting MDMA was really a big factor in those studies not being accepted.
Yeah, it's pretty obvious whether have been affected by that or not.
Yeah, yeah, yeah,
Yeah. Okay,
yeah.
thanks.
Yeah, no problem. No problem. I see some comments about light therapy. Yes, agreed 100%, Bridget. It is a fantastic treatment modality for a lot of patients.
I have a question. I have very similar views and experiences that you do with ketamine, with assisted therapy, and I think that's all like super exciting and hopeful. And um, but I primarily am interested in working with eating disorder populations. That's a lot of my clients, right? And these are like, as you know, like highly controlled individuals who
Yeah,
don't want to drink, let alone like go and take
yeah,
a, a drug like that. Do you think that there's any like hope or any kind of, because as you know, I'm sure the research with, it's like small amount of research that's been done with eating disorder populations, but it's like truly remarkable.
yeah,
And I'm just wondering like if there's like some kind of marketing that can come down the line or any kind of like additional evidence or what do you think like kind of from a perception standpoint for the general population needs to change for modalities like ketamine to be more
yeah.
um do you
I
know what I'm saying like
Yeah,
more
yeah, no, definitely. I think they need to be more accepted and more thought of. I think
right
number one, we need more research around treating eating disorders with ketamine. So there are much smaller and much fewer, many fewer studies
right
in eating disorders as compared to something like depression, for example. So I think the research needs to kind of catch up a little bit so that it becomes more accepted by providers. And I think the other big component of this is a lot of providers are treating eating disorder patients tends to feel a little bit riskier from a medical management standpoint because they can
yeah
be
that
medically unstable.
yeah
And there are cardiovascular risk factors with ketamine. And so I think the answer to that is let's get the research in place and then let's integrate ketamine much more tightly into those treatment paradigms. And so having them being ancillary services that are offered, or having it being ancillary service, an ancillary service that's being offered as part of comprehensive eating disorder treatment. We're not quite there yet with depression, but we're much farther along. But I think kind of building it into the paradigm is what we need to do. And I think that actually starts with like kind of clinicians first. And then once we are able to speak much more confidently about how effective it is, we can
Right.
kind of help patients, assess that risk benefit for themselves too.
Very cool.
Yeah,
Well, I have a hard stop at 11:30, but I just wanted
sure.
to thank you so much. That was all like
Yeah,
very interesting. And of course, stuff that like you mentioned is just not talked about enough, you know?
yeah,
There's
yeah,
a lot of hope and there's a lot of, strategies and interventions out there that,
mhm,
you
yeah.
know,
And
doesn't
I
have
think
to be medication,
doesn't
which is
have to be
scary because it
medication.
doesn't work very well most
It
of the
doesn't
time.
work very well for these patients, and I think this is also where kind of us as like med management and psychotherapy providers collaborating on care, that's where it gets really important. Building a comprehensive plan for each patient that includes all the things that might be helpful, which is kind of what we try to do at Continuity, and what I try to do is I kind of have these talks with other people in our community, to kind of facilitate us being able to do that for our patients. Yeah.
Very cool. Well, thank you for your
Yeah.
service.
Thanks for coming.
Mhm.
Any other thoughts or questions? Hey,
Um,
Kyla.
I don't, I don't know. Let's see. Is it a fully formed question? I
Yeah.
guess just based off personal professional experience, I had a client recently who I would identify as having treatment-resistant depression. She was doing ketamine somewhat irregularly. And thinking back, I think I've had one or two other cases like this. Any research or ideas about possibly, sorry, um, like borderline and treatment resistant depression? Because
Yeah,
that was some of the conceptualization that was coming up for me.
sure. Yeah. And I think, when patients present with like personality traits or a formal personality disorder, I think a lot of people, it's unfortunate that I think those patients kind of, it ends up being a label that, is something that a lot of clinicians have, feelings about, that may impact the kind of care they deliver. But I think treatment resistant depression is very common in those patients. Certainly, mood symptoms very much are. I think
Yeah.
the approach, is very similar, with an even lower kind of emphasis on the medication side of things, because the data shows the medications just aren't that effective, and so a lot of it's going to be, the psychotherapy, DBT skills, self-soothing, all that kind of stuff, kind of the basics of management, and then there is some data that interventional treatments can help. And so I think that's where kind of making sure we're diagnosing, this as MDD or a treatment resistant depression, not just borderline personality disorder, that kind of gets those patients access to these treatments that may be very helpful for them, especially with the cognitive flexibility piece, because changing how you think is hard. And these medications, especially in personality disorders, and these medications potentially could be really helpful, or these interventional treatments rather could be really helpful, not medications. So, right. Well, I think we're about out of time. I really appreciate everybody being here. We'll distribute the slides and the recording shortly, and thanks for having me. Yeah.
Thanks,
Well, have a
everyone.
great day.
We'll send it out to Kylie, an admin, and then she'll be able to get this all to y'all as well as soon as the video is uploaded. So thank you.
Thank
All
you
right.
guys so much. It's
Bye-bye.
good to have a good psychiatrist to refer to. So it's really nice meeting y'all.
Yeah.
Take
Yeah.
care.
Be happy to work together. Have a great day. Bye-bye.
Thank you.
Bye.